guys for having me. I am excited to be here to talk to you. Is everybody able to ask questions if they want to? Nobody's on mute, correct?
They can type it on the chat.
Okay, let me make sure that I can see the chat because I'm sharing my screen.
I can read it to you, the questions, if you want.
Okay, all right, that sounds good. So I'll kind of go through this and then I'll take my screen off once we get to the question portion, but go ahead and stop me if there's any burning questions throughout. And we'll just get started. So a little bit about me. Let's see. I am a wife and a mother of two kiddos. Sloan, that's pictured there, is 3 years old. And then Whit, who was in my belly during that picture, is now 6 months old. I'm a physician, board certified in internal medicine. I worked as a hospitalist after my training. And that's the picture you see there. That's my the NP that I worked with. Her name is Jennifer, and she was my lifeline while I was working. It was so lovely to have a upper level provider to help me with the busy rounds of being in the hospital. And I'm also practicing lifestyle medicine. I'll be sitting for the lifestyle medicine boards in November, and I am excited to talk to you a little bit about that too. It's a newer specialty that doesn't have a lot of residency programs, but are developing residency programs. And it's just something that I am passionate about and want you guys to be aware of. I'm also an entrepreneur. I opened an infrared sauna here in Austin. I'm really interested in things that have a lot of evidence-based backing with my background in research. And I had discovered this infrared sauna studio through my friend, but then took a lot of time to research it and found that the American College of Cardiology had used the same infrared sauna machines that this franchise did and showed a lot of improvement in cardiovascular markers. And so it's really like a wellness thing that people use. You know, it's kind of a spa-like atmosphere, but I really believe in it for health benefits too. So I did that. And then Rooted Fem is my new concierge medicine practice, which I hope to expand into a lot of wellness arenas. So why medicine for me? I think when I was young, my mom said something like, don't be an accountant like me, be a doctor like Kimberly. Kimberly was our neighbor. She was a fabulous female physician who really, I idolized and I could emulate. So then just with that kind of encouragement from my family and being able to see it, if you can see it, you can be it, it really reinforced my desire. And every time I was exposed to healthcare from then on out, I really just wanted to see more, and it just intrigued me. So I was always on the straight plan to go into healthcare. I started my undergraduate training at Elon University in North Carolina. I was a chemistry and art major there. And it was a small liberal arts college. A lot of people were in, majors like business, but there weren't a whole lot of chemistry majors there. I think in my graduating class, there were 9 of us. And so we had a lot of great support from our professors and anybody around who was willing to give us their time. They really, they knew what our goals were, and they pushed us to apply ourselves. And I really enjoyed going to Elon University. So is there anybody here from that side of town, from that side of the States? No? Okay.
I don't think so.
So then after my undergrad, I did a year of just working in the ER before I went into medical school. I actually then, my application wasn't strong coming straight out of college. I didn't have a whole lot of guidance from any family members. I didn't have family members in medicine. And so I I don't think I was as prepared as I needed to be for that application process. But then, working on it and persevering, and then I went to this Master's of Science in Human Nutrition program at Columbia University. It was a year program. So it was a nice gap year. It was a good way to build my resume. Although the week I started there, I actually matriculated into the University of Kentucky College of Medicine during the early admission process. And I just got to enjoy my year, really. So that was fabulous. Oh, and I want to just say, if you're into research and you want to consider a gap year like this and you're interested in nutrition, they're really heavy on research. And so you're kind of in this academic world, and it's really, it's rigorous and it's exciting. And if that interests you, I would definitely check them out. That's Sharon Akabus, and she is a fabulous, fabulous lady. She is the chairman of that program. And if you want any more information, I can give you my email at the end of this. So then I went to the University of Kentucky College of Medicine. I was originally from Kentucky. I'm born and raised in Lexington. That's my hometown. And my parents were there while I was in medical school. And it was a great center to be at because it was very big. It served, the University of Kentucky served most of central Kentucky, and we had all of the specialties you can imagine under one roof. And so we got a lot of great exposure to everything, and I loved it there. It was a great experience. And those are my buddies that I graduated from medical school with. Then I moved on to do residency. I did my intern year in internal medicine, actually at the University of Kentucky. I had originally applied for dermatology and didn't match, but then got a match at my home program, which was quite an honor for my preliminary year, because those are matched separately. And they offered me to stay, but I got engaged and I was very serious and with my relationship. And so I decided to move to Austin, where my then fiance was. And I finished out that 3-year residency program with the last 2 years in Austin. And that is the beautiful Dell Medical School. I actually didn't do my residency in that building or at the new hospital. I did it at the old hospital that's here, which is about to be torn down. But we have a brand new, beautiful facility here in Austin, Texas. And then, so what is internal medicine? And that's really what I'm here to talk to you about today, just to give you an idea of what it means to be an internist, as it's called, and to give you an idea of if this field of medicine inspires you. So you don't have to, so in terms of specializing, so you can specialize from internal medicine after you do the 3-year residency program. You can then apply for fellowship programs and become more specialized. And so the programs that require an internal medicine residency are these: cardiology, nephrology, endocrinology, oncology, pulmonology, or critical care. And there may be more, but I think those are the big ones. But you don't have to specialize. You could be a general internist and just know a little bit about a lot of medicine. And that's really what excited me. I couldn't decide. I loved everything. I loved renal and cardiology, and I loved it all. So I decided to stick with internal medicine. And you can do internal medicine in one of two ways. You can either become a hospitalist and work in that setting, or work as a general practitioner in a clinic, just as like a family medicine practitioner would do, although you wouldn't see children like they do. So as a hospitalist, which is what I was, you are an attending physician is the term. You admit patients to your service. So you just, basically your service is a list of patients that you are responsible for. And you care for them from the moment they are admitted to you, either from the ER or through a direct admission from the community, till they go home at discharge. And you do everything from ordering lab tests, ordering imaging, deciding what treatments or fluids they get, how often to check their vitals, all of that stuff. And then, like I said, they can come from straight through the emergency department. So as hospitalists, you actually spend a lot of time back and forth from the hospital, from the emergency department. And you can also get direct admissions from the community if you've built a repertoire of primary care physicians who, you like to care for their patients and you have a good communication. Then a lot of times they'll call you knowing that you'll get a good discharge summary to them after their patients leave, and they want you to care for their patients in the acute hospital period. And it's really just important to note that you get to see all kinds of patients across all kinds of specialties. And you work with all kinds of consultants. So when we admit patients to the hospital, we could have patients that are part of the cardiology service, part of the intensive care service, and maybe they're seeing 3 or 4 or more consultants during their visit, but you are the one that's responsible for their care. And you are that admitting doctor is the term for that. So that's what a hospitalist does. My day kind of looks like this. If you look over on the right-hand part of the screen, a typical day, I show up at the hospital around 7 or 8 o'clock, depending on if you're in private or a contract group of hospitalists. But you get your handoffs from the nocturnist, who's kind of just kept things quiet overnight. See if anything's changed or if any emergency calls came in. Then you start by sitting down at the computer and pre-rounding on your patients, checking your labs, any imaging you've ordered, things that weren't tidied up from the day before, checking those notes from consultants and all that stuff. If there's somebody acute, you can see them either before you pre-round or immediately after. I usually would have, as a hospitalist specific to the bone marrow service, I'd have a multidisciplinary meeting at 10 a.m. every day. And then I'd usually get a call sometime between that meeting to go leave and take a new patient on my service for an admission. And then I would round on more patients, take a lunch break, maybe around 1 o'clock, and get a couple more admissions through that break. In the afternoon, we might have a social work meeting where we just tidy up any pending discharges from the hospital and finish rounding on my patients and complete all my notes and leave around 4. And that was because I was in a private group. Excuse me. I have a tickle in my throat. So it's not unusual for a hospitalist's schedule to look something like working for 7 days in a row. So every other week you would work from Tuesday to Monday. So they always start it kind of on an off day because so much changes over the weekend. It's best not to have a lot of handoffs on that first day after the weekend. And then 7 whole days off where technically you don't have to do anything. A lot of my partners would go to the rehab facilities and, make extra cash by rounding on those patients, or the nursing homes around town. You can also do telemedicine services, consulting via telemedicine. And then as a partner in a private hospitalist group, we got to kind of make our own schedule. So as long as we were there to help the team take admissions between 8 and 2, we could leave whenever we were done rounding on our patients when our work was done. Very seldomly was that were we able to complete the work in those hours. But it was nice to have that option if you really had to get things done that day and you had some kind of appointment or had to go pick up kids or something like that. You could kind of move your schedule around, and everybody is really helpful when you're in that kind of setting. If you're contracted through a hospital group, like through a third party, their shifts are typically 12-hour shifts from 7 a.m. to 7 p.m. and you have to be there the whole time. In my group 2, we took call for admissions. So occasionally I'd have to get there early and stay late, depending on when my admissions were. And you'd have 3 of those shifts a week. And they were like 6 or 4 hours of just being in charge of taking the call for admissions from the ED or for direct admissions for the whole group. And then in terms of how many patients you would see a day, it would be about 14 to 30 patients on your list. And my average would be about 21 patients. And then I get about 4, I would say, admissions a day. You're also responsible as a hospitalist for arriving to any codes or rapid response events for your patients. So that's like when somebody isn't able to breathe, or, their heart rate drops, or they're becoming hypotensive, and you hear code blue, or rapid response to this room. You got to run, and you run the code. If another physician, like the critical care doctors also in our hospital, would show up, but if they're not there, then you're in charge of running the code. So a variety of cases. So this is just a list that I came up with in a quick 5 minutes. These are just cases that I see often. So it's really quite interesting to be a hospitalist, because you get the whole gamut. You get anything from just like a very benign rule out chest pain kind of situation, to somebody who's very critically ill with, sepsis, and they're in the ICU and they're having acute respiratory distress, and they may be on a rotary bed, or, have a lot of lines and vasopressors. So you're always kind of in the mix, learning something new, getting information from your consultants. And that's what really drew me to internal medicine. So I'm going to go through just a few cases for you. I've simplified them quite a bit, but if you want more detailed information, you can ask me about it in the questions once we're finished. So case number 1 is a 21-year-old male. He presented with, extreme muscle pain in all of his extremities, his arms and his legs. His muscles were swollen, and they were pink, kind of a reddish pink. Like his limbs were. He had mild fever, an elevated heart rate. He looked very cold and clammy. We call it diaphoresis, and he was a little nauseous. So when you go and you check out a patient, it's easy to jump into all of the signs and symptoms that are going on. But he was very guarded about what was going on. So we had to push him a little bit. Turns out he was rushing a fraternity, and they had him consume alcohol, copious amounts of alcohol, while working out and doing push-ups for like 6 hours, push-ups and squats. And so anyway, he came in with extreme muscle fatigue. So he was diagnosed with rhabdomyolysis. We'll go through that. Some causes of rhabdomyolysis are extreme physical exercise. You can get, if you have a lot of tonic-clonic seizures, that kind of muscle engagement for a long period of time can also cause rhabdomyolysis. Muscular trauma, when you get a crush injury, that can lyse those muscle cells and cause rhabdomyolysis. Some medications can cause lysing or breakage of muscle cells. Certain metabolic or genetic disorders, and then body temperature changes. So like heat stroke, or hyperthermia or malignant hyperthermia, like with anesthesia, can also cause rhabdomyolysis. So rhabdomyolysis itself is just the breakdown of the muscle cells, the sarcolemma that has all of the calcium and a lot of potassium, and the protein myoglobin, which is a heme-containing component of your muscle. All of that is, the cell membrane breaks, and that's all released into the system. So characteristics of rhabdomyolysis are tea or cola-colored urine. So that myoglobin is filtered out of the blood through the kidneys. It's a big protein-containing heme, and that heme molecule is brown. And you'll see sometimes when you have a bruise, or like a blood blister or something that's healing under the skin, it may turn brown before it gets better. That's that heme in your blood. But in this case, it's from the muscle cell. So you eliminate that through your urine and you get this tea-colored urine. You can also test for myoglobin in your urine with a urine test. But typically you get the test back for the creatine kinase first. And that's really the hallmark of rhabdomyolysis, is elevated creatine kinase in the blood labs. And that is just due to that muscle breakdown, and that's, again, it's filtered through your kidneys, and that is the skeletal muscle component. There's also a myocardial, or heart muscle creatine kinase, but this is the one from the skeletal muscle. So complications of this include acute kidney injury, and that's really due to a number of factors. So that protein is really big for your kidney tubules. Also, you get really dehydrated from this because a lot of the water in your vascular spaces is now entering your muscles. Your muscles are a big component of your overall body habitus. And so if they're all inflamed, then you're going to get a lot of fluid that is seeping into those muscles and not staying in your vascular spaces. So you don't perfuse your kidneys very well, and that causes an injury to the kidneys. Some really concerning complications are things like sudden cardiac death. And really great athletes, sometimes they have lysed their muscle cells and damaged their muscle cells so extensively that when they release all that potassium, it can cause a fluctuation in the electrical current, in the heart, and it can cause sudden cardiac death. But this isn't a heart attack. It's not like it's losing oxygen to the muscle like a myocardial infarction, but rather it's just the currents not being able to move because the electrolytes are imbalanced due to the lysing of those cells. Another big complication of rhabdomyolysis is acute compartment syndrome. So if you think about your muscle, it has a fascial layer around it, and it can only expand so much inside that fascia. And once it expands into that fascia, it's going to start compressing all of the nerves and arteries and veins that run through there. So you'll see with patients a lot of times, especially after they've gotten fluid resuscitation, that the fluid will get into their muscles, it expands the muscles, then they start to feel tingling because those nerves are being compressed, and sometimes they'll lose blood flow. So you always have to be checking. So we'll move on to management. So the management to help prevent that really common acute kidney injury is to fluid resuscitate, meaning to help perfuse the kidneys with fluid and try and get all of that myoglobin flushed out while hydrating. But you have to be very careful, and you also sometimes need to have a surgical consult because they may need to cut open that fascia if they're getting extreme swelling. You always need to be checking for the pulse, like we said, so you can avoid that compartment syndrome. Electrolyte monitoring, like we said, if you do have an elevated potassium, you can always, it's probably I would say a potassium of 5.6 or 6. It's really time to start thinking about adding something to lower that now. Loop diuretics will help you remove those through your kidneys as long as your kidneys are functioning properly. Insulin will help push that potassium back into your other cells. But again, if a lot of your skeletal muscle is lysed, that might not be a great idea. And then albuterol also helps to lower your potassium. It's a beta agonist property. So then another important thing related to the potassium is putting patients on a cardiac monitor or telemetry and getting frequent EKGs just to monitor for any cardiac abnormalities, and then pain control. So our patient did really well. He really just needed pain control and a little bit of fluid. He did have quite a bit of swelling, but he never lost feeling or blood flow to his extremities. So he never had to have any of his fascia opened in order to prevent compartment syndrome. So he did well. He ended up improving and left the hospital 5 days later. Um, so this is, I'll go quicker through these next. I have two more cases. So this is a 42-year-old female. She presented with this rash. It's called Petechiae. It doesn't blanch. So like when you press on it, it doesn't go away. So she also had fatigue and a rapid heart rate and a platelet count of 6, which is extremely low and scary. Hemoglobin was low, and so was her white count. So one thing about, what was I going to say about petechial rashes? So they can be caused by a lot of different things, but, on her labs, that pancytopenia, all 3 of those lines from your hematopoietic and hematopoietic stem cells were low. So that led us to want to do a bone marrow biopsy. And so here you can see these 2 slides of bone marrow biopsies. They came from New England Journal of Medicine, but one is very hypocellular. You don't see a lot of cells. You see a lot of fat globules in the bone marrow, and that's classic for aplastic anemia. And then there's the normal bone marrow on the right. And so basically this aplastic anemia is characterized by pancytopenia with your hematopoietic stem cells being replaced with these fat globules in your bone marrow. And the most common cause of a sporadic aplastic anemia is an autoimmune cause. You can also have, there's quite a few iatrogenic causes, whether those be medications or chemotherapy or radiation, and some genetic disorders can also cause it. So our patient came in with really, really low platelets. She had to get a blood transfusion. Of course, I was seeing her as a hospitalist on the bone marrow transplant service. She was a bone marrow transplant patient when she came in. And some of these patients, if it's severe, do require a transplant of stem cells. Then immune suppressive therapy is also important in some cases. There's a newish stem cell stimulator called Promacta. It's a thrombopoietin agonist, which means it increases that cell line, but it actually has shown improvement in all the hematopoietic cell lines, and hormone therapy as well. So just those top 3, that transfusion of blood products, a bone marrow transplant, and immune suppression are the most common forms of management for these cases. So complications can be bleeding, any kind of bleeding. Intracranial hemorrhage is the most severe because the cranium is closed. It's not an open system. And if you bleed into your brain, it pushes your brain down through your foramen magnum where your brainstem sits, and it can cause brain death. And then hemodynamic instability. So if you don't have enough blood cells, your heart sees that as not enough blood or volume to get it oxygenated. And then without oxygen, you could have a heart attack, you could have heart failure, you could have failure from any number of organ systems. Neutropenia is a big risk here too. Without your white blood cells, you can have quite a severe infection. And then hemochromatosis happens after you get too many blood transfusions. So sometimes these patients, especially if they're autoimmune in nature, will be refractory to transfusions. So if you think about it, they just will clear these things, and their autoimmune cells can also attack the blood cells themselves. And so we had a patient who was refractory to steroids and transfusions, and she was started on 2 separate immune suppressive therapies and Promacta at the same time. While after, I think, her first dose of those things, she suffered an acute intracranial hemorrhage. She had a headache. They checked her platelets. They were down to 3, and she actually didn't make it, sadly. Okay. Let's go through this case number 3. So this one is interesting because this was such a young patient. I know if you guys are only in college, 39 may sound old to you, but that's young in terms of healthcare. You don't expect patients to be very sick when they come in and they're 39 and they don't have any medical history. So this gentleman presented 39 years old, previously healthy, had never had any medical problems to his knowledge, although, you may see that some are undiagnosed when you get patients into the hospital. But he complained of 3 days of fever and just extreme shortness of breath that brought him into the hospital. He was kind of, a tough guy to get to the hospital. So he must have been feeling really bad if he finally ended up in there. So he was in the emergency department on 6 liters of oxygen via nasal cannula. That's that little tube that goes in your nose. And his oxygen saturation was around 94, which isn't terrible, but we want it to be in a healthy individual, 98, 99, 100%. He had a fever at the time and some mild tachycardia. So I was called from the ED to come and see him. At the same time, they had gotten a chest x-ray and let me know that he had bilateral lower opacities, lower lung field opacities. So it was pretty certain that he had, a pulmonary infection. He was started on IV fluids and empiric antibiotics before I saw him, and multiple electrolyte abnormalities on his labs, which isn't too uncommon when you're ill, because he probably wasn't eating or drinking very much, which makes you very dehydrated. And then those things can be thrown off very easily. He had an elevated neutrophil count. So neutrophils are polymorphic immune cells that indicate that he most likely had a bacterial infection, but he was also positive for influenza A and the strep pneumoniae. That's not spelled correctly, by the way. That says pneumonia, but there's supposed to be an E on the end of it. His urine antigen came back. So he had not only had a viral infection, but he was secondarily infected with this bacteria. So after that, he actually had another chest x-ray, which showed fulminant opacities bilaterally. So what we see is a lot of times these patients that have really bad respiratory failure or respiratory infection, once you give them fluids, just like when you give somebody with rhabdomyolysis fluids and it goes to the area that's inflamed like muscle, you can think of the lungs the same way. If they're inflamed, those capillary beds have been compromised and water will rush into that. And that kind of puts you in this acute respiratory distress syndrome arena. By the time I saw him, his oxygen saturation had dropped to 88%. He was on a mask now, with a non-rebreather mask, which takes away any of the CO2 to try and give some more ventilation. And he was working really hard to breathe. His blood pressure was trending down. And I immediately called the pulmonologist, or the critical care intensivist is another name for it. And we started him on BiPAP because I could tell that without any pressure into his lungs, we weren't going to be able to ventilate him or oxygenate him very well. In this, within a few hours, his gram stain had come back, and it was just florid with gram positive organisms, which was consistent with his urine antigen. And he had a lactic acid level of 8, which is extremely high. Normal is less than 2. So he was transferred to the ICU. He was intubated as soon as he got there. His pressure continued to drop, though, unfortunately. So they placed some lines. A central line goes either subclavian or internal jugular straight into the heart space, where you can monitor pressures and you can give drugs that can't be given in a peripheral line. And that's how you give vasopressors for blood pressure that isn't controlled with just fluid alone. And then we also placed an arterial line for better blood pressure monitoring. He was stabilized for a brief period in our ICU, but then this was when I was in training. He was transferred to another facility, and he was actually placed on ECMO, which is when they take a cannula from your heart and put a cannula on the other side of your heart to go to your body. So they bypass both your heart and your lungs because neither of them are working properly. So he was hypotensive, couldn't keep up his pressure, but also he wasn't oxygenating very well, even intubated. Very, very rarely does this ever happen. But I did get word that this previously healthy 39-year-old did make it off of ECMO and survived this very extreme case of sepsis, septic shock. So let's talk a little bit about sepsis versus septic shock, and the precursor to both of those is SIRS, or systemic inflammatory response syndrome. So you can have an inflammatory response for all kinds of reasons. It doesn't have to be an infection. And so the criteria to meet that is having these temperatures. Usually it's a high temperature, so over 100.4 Fahrenheit plus, 90 beats per minute of heart rate or accelerated respiratory rate and elevated white blood cell count. So he met, I think, all of these criteria when he came in, plus he had an infectious source, which we could identify through his chest x-ray without knowing his gram stain. And he was termed septic. So he was in sepsis. So that has specific criteria and protocol on how to treat. We'll go through that in a minute. But also because his lactic acid was elevated and he was requiring vasopressors to maintain his mean arterial pressure, he was in septic shock. So that's the extreme of sepsis. So there's even a qualitative severe sepsis, but we're not going to talk about that today. So you can talk about the prognosis for somebody with sepsis based on the related organ failure calculator. And when you see these things in somebody with sepsis, you can kind of tell just how terribly they're being perfused throughout their body. So if you're not perfusing your liver, you're going to get an elevated bilirubin. If you're not perfusing your brain, you're going to be obtunded. And so there's a Glasgow coma scale to evaluate that. Kidneys, if you're not perfusing your kidneys, you're going to get acute kidney injury, which always presents itself as elevation in your creatinine. Heart disease, or if you're not perfusing your heart, you're obviously going to be hypotensive in all your vascular spaces as well. If you're not perfusing your skin, then you're going to be really cool and clammy because there's not a lot of blood flowing there. And then your GI tract isn't going to be moving as much. It's not going to have as much motility if you're not perfusing that arena either. So how you manage it is by giving a lot of fluids early. So 30 milliliters per kilogram of ideal body weight. Most people are 70 kilograms. So, that works out to be a couple of liters right away. And you usually have to push those under pressure to get them in. Empirically, you treat them with antibiotics, like a broad spectrum of antibiotics. So it's usually 2 antibiotics that cover most gram positive, gram negative, and some of your nosocomial infections, like hospital-based infections, if they're at risk, and some atypical things. And then you just target those antibiotics and you narrow those down based on your culture data after you get blood cultures. And then you want to stabilize them in their respiratory status. And usually that just involves getting intubated, being placed on a ventilator. Rarely do these people ever need ECMO. I think I mentioned a rotary bed earlier. Rotary beds are great for patients who have progressed from just a pneumonia situation to acute respiratory distress syndrome, where all of their lung tissue is really frothy or hazy on chest x-ray. That kind of means that the whole lung is involved. But if you can rotate them so they're face down or prone, you can utilize the largest part of your lungs, which is in the back. So you may see that sometimes if you ever shadow in an ICU. And then obviously septic shock requires an ICU admission and vasopressors, and you just monitor for the resolution of that lactic acidosis that is part of the criteria for septic shock. So this patient did extremely well for somebody having to get on ECMO, which you probably wouldn't expect in terms of all that he had to go through to get well. Once you're on ECMO, it's very scary. So moving on, so I'll just say that hospital medicine, in going through this presentation and trying to, find things from my memory to talk about, I left my hospitalist job in February of 2020, just before COVID hit, which was really just a coincidence, but I was pregnant. So it was a blessing for me, kind of in disguise. But going through this, I really do miss being in the hospital. The hospital is such a great, exciting place to be. Lots of learning, and just like really being in that scene is so exciting for any kind of physician. So I do miss that. I do miss that vibe, that energy, but it is very grueling, and there is a high burnout rate. So we'll talk about taking care of yourself at the end of this, but I just want you to know that even though I left hospitalist medicine, I really did love it. So I moved on to lifestyle medicine. I have a real passion. I did a master's in nutrition for people taking care of themselves in terms of nutrition, exercise, and taking care of stress. Personally, when I was working in the hospital, I had a lot of stress. And I know that when I was about 30 years old, I went to a primary care doctor, and I wanted to be taken care of. I wanted somebody to tell me all of the things I needed to do in order to maintain the health that I was enjoying at the time. But, they just looked at me like, I got nothing for you. If you don't have a problem to treat, then I don't understand what you're doing here. So she just ran some labs and did an EKG, and everything turned out okay. I was already up to date on my female screening. So I left that office kind of feeling like, okay, that didn't really do much for me. And, I feel all right, but how do I know I'm doing all that I can do for the best health, for longevity, and to decrease my risks of disease in the future? And that's how I found lifestyle medicine. And it is all evidence-based. It's a total legitimate practice of medicine based on lifestyle interventions. And so it is administered by clinicians. It can be an upper level, health professional like an NP or a nurse practitioner, or a physician's assistant, or it could be a physician himself. There's also a lot of nutritional counselors and dietitians that have, their segment of lifestyle certification, but it's we're trained to prevent and treat and often reverse chronic disease solely through therapeutic lifestyle intervention. And it is the foundation of conventional medicine. So once you get to medical school, you'll learn that a lot of medicines, a lot of chronic disease, especially the ones that are westernized, like heart disease and diabetes, obesity, and what else? Not really so much cancer, but cancer is affected by all of this. The first line of treatment for those is usually lifestyle modification. And as doctors, we usually scoff at that. Like, there's, okay, fine, that's all good and well, but patients rarely change their habits. So here's a pill. And all of that kind of focus and attention in medicine has accelerated our healthcare costs. And it's really put a lot of people into the healthcare system who could otherwise be enjoying a really great life. And I really wanted to be a part of that. I felt like I was in the hospital just waiting for people to come to me to get sick. And at the same time, my own health was deteriorating. So that's what led me to all of that. And so, yes, so it's a foundation from conventional medicine. And you actually have to carry a board certification in an accredited board from the American Board of Medical Specialties. So because I'm an internal medicine trained physician, I can sit for the lifestyle medicine board exam. And let me think, what else? Okay, so chronic conditions like hypertension, heart disease, stroke, type 2 diabetes, things I've already mentioned, osteoporosis, autoimmune disease, some cancers, specifically the ones that are the top killers of men and women in our country, like breast and prostate cancer, can be preventable through lifestyle changes. And those lifestyle changes that have been proven through evidence and research are your nutrition, and that's really a shift towards a whole foods, plant predominant, nutrient dense diet. Exercise, physical activity, and there's specific recommendations about the intensity and the amount of time you should get exercise a week for the most benefit and mostly your cardiovascular health. But exercise also increases your immune function and also decreases your propensity for breast cancer and prostate cancer. So if you're getting 150 minutes of moderate exercise, which is about, I think 50 to 70% of your max heart rate, or if you're getting 75 minutes of strenuous exercise, which is more like 70 to 90% of your max heart rate, then you're really at that threshold for having significant benefit to your mortality and chronic disease reduction. Restorative sleep is really important. People who get 8 hours of sleep a night spend enough time in that restorative REM cycle that really helps with cell turnover and helps with our immune function and our healing processes. And so we've seen that good sleep hygiene and habits really do promote longevity and decrease disease risk. Stress management, I can't emphasize this enough if you guys are all going into medical school, but stress is a killer. It does decrease your telomeres, which is the little cap on your DNA that prevents them from unraveling. Once it's gone, and your DNA unravels and it causes aging, but you can increase those telomeres by these lifestyle changes. And, stress is a big one. So everybody does have stress. It's just how you manage the stress, whether you are able to internalize it and see it and focus on it, and if you can turn it into a positive. So your body doesn't know the difference between I have a paper due tomorrow and I'm running from a tiger. It just releases the same cortisol, and that cortisol, if it's remaining high, it's going to cause some increased aging and some free radical damage and all of the things that cause premature aging and increase your risk of DNA damage. That DNA damage then causes your body to turn on the wrong genes, and those cause disease. So manage your stress. Okay. Avoid toxic substances. Those are alcohol, tobacco, and illicit drugs. Of course, we all know now tobacco is terrible for you in terms of your vascular health, your lung health. Illicit drugs, I'm sure you guys know, they're not great for you either. But then alcohol has kind of been the one that's lagging behind. A lot of people drink alcohol, but a lot has been shown about longevity, whether your mortality is higher if you have more alcohol. Now, there's some studies that 28 grams of alcohol a week for women improves their cardiovascular risk. Now, is that confounded by the fact that maybe that amount of wine is a stress reducer for those women? Perhaps. A lot of times you find, though, people who drink a lot more than that. And after that threshold, it becomes a negative. So alcohol is a big one. It's probably going to be talked about more and more as people catch on to the idea that it really is not great for your health. Then positive social connections or support, loving relationships. If you've got everything going for you, but you don't feel loved and you don't have friends and you don't have someone to talk to, your health is going to deteriorate because of that. Your health is really benefited by having loving connections. And I think there's a study, and I hate to quote it without knowing exactly where it came from, but I think people on average need about 9 hugs a day to help the quality of life. So with the pandemic, we've seen there's just like the amount of mental health that's happened in the past year because we haven't been able to be in these social connection spaces it's really skyrocketed, and it's actually quite scary. But So I encourage you to stay connected with the ones who either, are vaccinated or have been really careful, or through FaceTime. So that will help your health. I see a lot of patients who come to me. My practice is let's say targeted towards women in their prime, kind of in that post-college to like mid 40s age, who haven't quite ended back in the healthcare system, and they're creating habits for their growing families. But at this time, they're thinking they're really fatigued all the time. They don't have energy. They have difficulty losing weight, which is a lot of times a factor of stress and sleep, not so much that they're exercising and eating okay, although those all play a role. People with high blood pressure, high cholesterol, infertility is a big motivator. If you really want to have a baby and you're not able to get pregnant, people want to do anything that they can control to try and get that process on the way. And so I help patients, I counsel them on their nutrition and their stress management through that process. And anybody who really wants just wellness guiding, like myself, where I wasn't really sick, I wasn't having any trouble with my weight, but I just wanted to know what it would take to stay healthy and live the longest, best life possible. So I get those patients too. Of course, patients with chronic disease. And, I'm always happy when I can see somebody's need for blood pressure medications or cholesterol medications or insulin go down. So that's all exciting. So a typical day for me now is much different. Is I go into the office around 9. I leave every day before 4, actually, because I get home to my kids at 4. We have a nanny at home, and she always leaves at 4. I do administrative work in the morning. Developing a practice is really hard. There's a lot of steps, and you don't always know all that it entails until you start that process. So I do that in the morning, whether it's connecting with, labs that I'm using through my new EHR, or talking to my very niche attorney who is specialized in telemedicine, concierge membership practices, private practices. I'll review lab work or emails from my patients. I'll see about 5 patients a day, as opposed to like 30 patients sometimes in the hospital. And I get to like really spend time with them. I give them a whole hour of my attention, which you cannot do when you're being reimbursed by insurance to this point. I don't see anybody being able to make a living off of that. So I only accept cash for my patients in a membership setup. And then at the end of the day, I send all of my patients I saw that day a follow-up email about what we talked about. And, I give them homework to do for the day, and kind of just get them excited and get them involved in the process. This new way of practice really gives me a great doctor-patient relationship. And I can give these patients accountability where, otherwise they're not taking the time to focus on their health. We focus on so many things. We spend money on going to the dentist, or going to get a massage, or, these things that feel good in the moment, but or, maybe a trainer or the gym or whatever it may be that you kind of do for self-care, when really the best self-care is to actually just take inventory of these things for your health, and try to better yourself little by little. We all end up with these habits, and we just accept them without the knowledge of how they're affecting our long-term health, or, maybe prematurely going to take years off of our lives. And, if you can keep a patient out of the healthcare system, that's always a big win, because that means that they're able to enjoy their lives the way they want to. And if you talk to anybody who's sick, they'll tell you the biggest thing that they took for granted was their health, and they would give anything to have it back. So it's just important that people get the education that there's stuff that you can do so that you never have to lose that health. And personally, I get to avoid burnout. I saw a lot of doctors in my position who didn't have a good balance. They were letting work consume them, particularly some really high functioning physicians or specialists that I saw. One who, was running a marathon. He took care of himself otherwise, but just had a lot of stress in his job and had a heart attack and nearly died, and luckily didn't, but he afterwards changed his whole work schedule. And he knew that the stress of being the high functioning specialist he was taking a toll on his health. So I encourage anybody going into healthcare to really try and find a good balance of that. My advice for pre-med. So I'm trying to think what I would want to hear when I was going into medical school. And, if you guys all have great study habits, that's great. But find what works best for you. Don't compare it to others. If you're not great at studying right now, you can improve. It can, focusing takes practice. And I didn't learn that myself. That's something my husband, who is a Major League Baseball player, told me, that you have to practice that focus. There's no way you get better just by a passive approach. And then just taking care of yourself physically and mentally, check in with yourself. If something's not right, talk to somebody, a friend, a mentor. If you know something's not right with your mental health, please, please, please go see somebody. Don't be ashamed. I think we put so much negativity around mental health when really the people who are the strongest are the ones who are going to take care of themselves. And that really should be applauded instead of ridiculed. And then time flies. When you're in medical school, you get material every day and a ton of it. It's, they teach it quickly and you're in lecture and you get, and the way mine was structured, we got 4 hours of lecture in the morning, and there is no way you could not study that material from that day and expect to retain any of it in the long term, because the next day you were just going to get more and more material. So when you get to medical school, study all the time. Do not procrastinate because you will regret it. Any questions? I'm going to stop sharing my screen.
I have a couple questions in the chat. The first one says, in case 1, did the patient's alcohol consumption lead to his rhabdomyolysis, and how?
So it didn't actually, but it probably did incite some dehydration. So when you do consume alcohol, you decrease your antidiuretic hormone. And let me say, am I saying that right? Yeah. And so you diurese. And so then he was probably a little more dehydrated, which probably made his case a little bit worse.
And Jasmine asks, what do you mean by refractory to medicine?
Oh, okay. So this patient, all of her cell lines were low. And as we were giving her transfusions and we were giving her medications, you expect to see that those cell lines start to regenerate and that those laboratory values start to improve. And she never did. She was just refractory. Like, it did not help. Does that make sense?
Yeah, that did help. Yuna asks, do people come to you for mental illness, or do you just focus on physical wellness?
So I am not a trained psychiatrist, and that's an important point about lifestyle medicine. Everything that lifestyle medicine teaches is that it's a multidisciplinary approach. So I have great resources to send people to mental health professionals. And I always tap into how their stress is. So I have screening evaluations when patients come to me, especially if they haven't been seen a mental health professional. And if they need to, then we send them to those people.
And Sam says, is burnout common within internal medicine?
Yes, it is, especially in that hospitalist position. So you just got to take care. And for some people, it's not an issue at all. And for some people, it is a big issue. I wanted to be all of the things to all of the people. I wanted to be a great wife, and I wanted to be a great mother, and I wanted to be a great doctor. And I put a lot of stress on myself. And so I think for me, as much time and attention that I was focusing on it without really paying attention to like my physical health or my sleep cycles or anything like that, I was all around not healthy, and that led to my burnout.
And Kara asks, how do you feel like you manage your work-life balance as an internist in lifestyle medicine, especially with a family?
Oh, okay. So right now it's great. I can make my own schedule. Um, and you can do it in hospitalist medicine. So I will say this, when I decided to do internal medicine, when I didn't get into dermatology, I was looking around at the people who were the happiest. And at my program, it was the internal medicine residents. The surgeons were always tired, the OBGYNs were always tired. And that's just, that was just what I saw. I remember I had worked in the ER or the emergency department before I went into medical school. So I thought I would be an ER physician, but I talked to one of the doctors I worked under, and she was like, if it were me, if I did it all over again, I wouldn't have been an ER physician. And she, just wanted to stop practicing medicine altogether and go, be a stay-at-home mom. And I was like, oh, well, then obviously this isn't for me because I want to have both. And I think that you can find it. And I think there's not, a lot of people say it's not like a work-life balance. It's one and the same. So like, you just have to decide what you want out of life and then ask for what you want. Look at your contract and say, does it match what is appropriate for me, and ask for what you want. Like if you don't want call and if you only want a certain patient load and you always want to be home for so and so at this time, in some cases it's possible to get what you ask for, but you get 0% of the things you don't ask for. So ask for those things up front. If they don't give them to you, then you're right in the place where you started anyway.
Thank you. And one last question from Kate. Could you give an example of a typical treatment plan that you prescribe for patients in your clinic?
Okay. So, well, here's the honest truth. It's like patients, I've just started my new practice, right? So a lot of the patients come to me, they're already on a medication regimen, and I can look at their medication regimen and I can say, all right, well, I see something, I go through their goals. And then I'll look at their medication regimen and say, well, I have some goals of my own. And, I see that you're on a statin, and I see that you're on a blood pressure medication, and I see that you're on an antidepressant, and I see that you're on an anti-anxiety medicine. And you also have to take Miralax because, you're not having normal stooling. And so I will keep patients on those, and I will, we'll discuss those each time. And but what I will do is I'll go through each of those lifestyle factors. In fact, I add hydration and oral health to them because those particular things also have a lot to do with chronic disease. But we'll go through all of those, and where I see glaring issues, and a lot of times it's nutrition, but it can be throughout. I'll make recommendations like, okay, let's discuss how much fiber you're getting in a day or what calorie dense foods you're getting in a day. And so I'll make a lot of homework, or I'll do a prescription for exercise. And then it's fascinating to see how quickly we see blood pressure come down the next time. And so when I sign people up for my membership, I send them a blood pressure cuff and a pulse oximeter. I even send them, I suggest a scale for them to get, and I send them a Taylor tape measure so that they can take their waist to hip circumference. So I can kind of know where they stand on that metric. And anyway, so I've seen that patients' blood pressures go down within 2 weeks of working with me, just focusing on maybe 1 or 2 changes in their diet and maybe adding 1 day of exercise a week. And it's really quite encouraging, the bounds that you can get in if you emphasize that and you have accountability from your patients. A lot of times patients go home and they hear what you said, but they don't really think you're serious about it. Yeah, sure. Everybody says I should exercise, but I've got stuff to do, But if they are in your office, that means they're already taking a proactive approach towards their health.
Hi, doctor. Do you have time for one last question?
Hey, I sure do. Yeah.
Jasmine asks, how did you make the decision to start your own practice, and do you like it more than hospital medicine?
So I was already an entrepreneur. So starting your practice is not, I'm not going to say it's not rewarding. It's very difficult, right? And it would have been a lot easier for me to go from a clinic setting to starting my own practice. And it's a lot of overhead and it's a lot of time. So you end up working like an 80-hour week just so eventually you could work like less than 40 hours a week and make your own schedule. So right now it's very hard. Right now I will say that like sometimes I miss the comfort of everybody, all of the administrators doing the things for me at the hospital, controlling the billing and making sure the labs are collected and making sure all the paperwork is done. And setting up, like you have all kinds of things to set up. Like if you want to prescribe controlled substances, you need this particular token that gives you a reoccurring code to use. And there's just so many intricacies and having to deal with lawyers and malpractice insurance, that this part of building a practice, the getting it up and running and getting your patient load is very hard. But I think it's going to reap benefits for me in the long term. And particularly what I'm practicing, I'm also practicing in my own life. And so I think if I were just making my own business based on anything and it wasn't wellness related, I might not be doing so well with my work-life balance and with my happiness level in terms of getting it going. But because I'm so focused on controlling my stress and taking care of myself in terms of diet and exercise and stress and getting support from my husband and really talking about those things, avoiding all my toxins, like I feel good. And I know that I'm going to be bringing an invaluable service to my patients. So I can say in the future, I think this is going to be, the best move I've ever made. But right here in this like interim before my patient load is where I want it to be. And with all the extra work, it's pretty challenging.
Well, thank you, Doctor, for the very informative and inspiring presentation. I'm pretty sure we all learned a lot from this.
Okay, and I'll just give you a hint that all of the answers are in green.
Gotcha.
Okay, all right, you guys take care and feel free to contact me. It's Brooke at rootedfem.com is my email. If you guys want to reach out, you can also follow me. I forgot to put that up, but Brookie Stubbs MD on Instagram. So there's an I before the E in Brookie Stubbs MD on Instagram.
Did I get that right on the chat?
Let me see. There's no dot. It's
Okay.
just Brookie Stubbs MD on Instagram, or you can follow Rooted Fem, all one word, on Instagram, or you do Brooke at rootedfem.com is my email if you have any questions.
Well, thank you, Dr. Brooks, again.
Thank you. You guys have a great one. Good luck with everything.
Thank you. And all of you that are attending right now, I have posted the link to the forms. Let me do that again. And you can take the assessment for your hour for the session. And our next session is going to be held on the 21st. Oh. There we go. Thank you very much, guys, for joining in again.